Okay. So in infants, their poop depends on whether they're breastfed or they're formula fed. So since breast milk is perfect for a
I
kid's
know that
guts.
because I breastfed my kids.
Me too,
Yeah.
forever, too long,
Yeah.
probably. So breastfeeding is so easily digested that it looks yellow, it is very loose, it is seedy, and they'll have anywhere from 2 to 10 bowel movements a day. And they can go a long time too without pooping, and they're not constipated because their gut so easily absorbs it. So we all remember it's consistency over frequency, right? So I used to do PD triage and outpatient. I cannot tell you how much parents obsess over the kids' poop. So it looks,
Yeah, I
we
bet.
always ask more what the kid looks like, right? Are they comfortable? Are they still eating? Are they screaming all day? Like that's more of an indication than anything. Formula fed because it has a lot of iron, they typically tend to get constipated more. Yeah, and it looks more like brown. Sometimes it's pasty, and they'll have usually a couple bowel movements a day, but formula fed babies can go a while too without pooping, but theirs usually will end up in constipation, whereas breast milk will not. What's wrong? Oh, somebody's calling me. Oh, do you need to answer? Okay.
I definitely am not answering.
Okay.
Yeah.
All right. So toddlers, now they do not develop bowel and bladder control until at least 18 months. Okay. It is physiologically impossible for them to potty train before that. Okay. So this is where we see a lot of abuse cases because parents have a misunderstanding of what is actually developmentally appropriate for their child. Kids cannot hold their bowel or bladder before 18 months. They cannot do it, right? And so I was a child abuse nurse practitioner for a long time. And we saw a lot of child abuse cases like that because the parents thought the child should be potty trained by 15 months. And every time the kid had an accident, they would hurt them, right? It was horrifying. So they do not develop any bowel or bladder control till 18 months. And kids and adults, and this is pretty much for everybody, but the big overlying thing is consistency over frequency, right? So if you're trying to figure out whether somebody is constipated, the question you ask is, what do your bowel movements look like rather than how many are you having?
Right.
Okay, not that I'm not going to ask, I still will ask, but I want to see more like what it looks like rather than how many times a day. Because sometimes when people are constipated, they may go 10 times a day, but it's a teeny amount and it's very hard and they have to strain, you know.
Yeah.
And older adults, we know they get constipated. And then we talked a lot last time about impaction and obstruction. So you should be very well versed on that. All right, real quick on the nursing care right here. Okay, so just basic nursing care of a patient with any kind of bowel elimination problems. Okay. We know to emphasize a high fiber diet. Remember, fiber needs fluids, otherwise, fiber is constipating, right? So, fiber plus fluids moves it. Yes. And they often ask for nutrition purposes and things how many grams a day that people need 25 to 30 grams a day. You will never in nursing school not pick small, frequent meals. You will pick that for the rest of time. Okay.
Yeah,
always pick small, frequent meals because there's never a time you're going to say have one big nasty meal a day, right? We're not going to do that. Make sure they take in lots of fluids, and ideally, of course, that's 2 to 3 liters. And then they need to move, right? So anytime we're talking about constipation, it's FFM, fluids, fiber, mobility, right? Set them up on a bowel regimen. When they say that, that means like, remember how we talked about scheduled toilet time? You put them on the toilet at certain times, and then we decide in their bowel regimen, do they need a stool softener versus a laxative, right? So stool softeners typically just make it soft and the patient will go on their own. A laxative, most of them will move the bowel, right? Remember, 7 days max for any of those, right? Otherwise, you get dependent on them. Okay.
That's what we were told.
Yes, it's not meant to be long term. Make sure they have easy access to the bathroom. We talked about that last time, and that they have privacy. Okay. And then the bowel retraining program, we also discussed that last time. Remember, we have to do stool softeners. That time we will do 3 to 6 months because they've lost the fibers in the rectum. And remember, they can't feel anymore. Right. And so we do have to do it longer term for that. Okay. Monitor bowel sounds. Okay. And remember, in order to say they have no bowel sounds, which is a red flag emergency, you have to auscultate for 5 minutes in every quadrant. That means I have listened to their belly for 20 minutes and I heard not a peep. It's not common. So
it's okay if you hear maybe it out of 2.
Well, you want to hear something, right? Something is moving. Okay.
You just hear it out of 1 or 2.
Which is, it's fine. There has to be something moving. But if you say there's absent bowel sounds, that is an emergency. You should be calling the physician immediately. Like, so never pick, oh, I just say it's absent bowel sounds. You better have listened for a long time before you say that, because they're going to start preparing that patient for surgery, thinking they have a paralytic ileus. Okay. So that's a big no-no to document unless you really mean it. Yeah. So like after surgery, remember their gut can get paralyzed and it doesn't move. That's an emergency, right? And we can't feed them. We got to do all kinds of things. Okay. Daily weights and I's and O's. Which one is more important? It's still in nursing care. Daily weight and eyes, nose. Which one is more important? Don't worry about finding it. Just which one do you think is more important?
Oh, daily, daily what?
Daily weight or eyes and nose?
I would say weight.
Yes, it is always going to be daily weight over eyes and nose. Okay, because a lot of things can impact your intake and output, but your weight is the best indicator of fluid balance. Okay. Make sure no matter what their bowel elimination problem is, we're doing good perineal care. I think we talked about that last time too. All right, let's go right underneath that where it says abdominal assessment. This is the only time in nursing where these go in a different order, right? Most of the time you inspect, percuss, palpate, auscultate, right? Because it's a different order than every other body system, they usually test on it. Okay, so we're going to inspect first, right? So we want the abdomen to be soft and flat. Now, I'm not going to say a big overweight person is flat, but you can say it's rounded, okay? But if you say distended, that's another red flag thing. Distension means there's fluid and there's gas, and it's usually kind of firm to the touch. So if you say distended, you have to do something about it. If they're just overweight and they have like a larger, you can either say rounded or you can say a pendulant abdomen. That's a nice way of saying pendulant. That's a nice way of saying this is fat. Okay. If you see abdominal rigidity, that is one of the biggest red flag GI system assessments.
So it's just hard.
Hard as a rock. That is an emergency. You report that immediately. They call that either a surgical abdomen or an acute abdomen. You probably have peritonitis, which is inflammation of the peritoneal cavity. So that means, remember we talked about that, either you have a bowel perf or like your appendix ruptured, something very bad happened. So if you ever see rigid board-like abdomen, that is the number one assessment. That is a giant red flag that you need to report immediately.
So is that what happens if it is appendicitis?
If appendicitis ruptures, right? So if it ruptures, that means the appendix has ruptured and pieces of appendix and poop are all inside the peritoneal cavity, okay? All right, so then we are going to auscultate. You've got to do that in all 4 quadrants, and you can either say they're normal active, hypoactive, hyperactive, or absent. If it's absent, you better mean it.
Hyperactive mean? Like constant?
Yes. You know, like when you're real hungry and you can like hear that's what it kind of sounds like. You know, sometimes we do that when people have been NPO and your stomach's just growling, right? Your gut is just moving. You can hear that when patients have really bad diarrhea because their gut is moving very quickly. Yeah. So you'll be like, oh, this thing's a moving, right? And that's not a red flag. It's just things are moving quickly, right? I hear this in kids all the time. Someone's like, oh, you must be hungry, or I hear your pancakes inside here, you know? And then percussion, I don't see nurses doing that very often, but you can do it. Yeah. No, you put your hand like this on their abdomen, and then you can either use your finger to tap, or I use my stethoscope, the end of my stethoscope to tap. And it should sound hollow because most inside of there is like, you know, gas and fluid and things like, you know, just like hollow things. I use it to see, we can use it to see too how far down your liver goes to see if you have an enlarged liver. Okay. Because it should be hollow, 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 hollow. Your liver should follow right where your ribs are. But if I hear like dull sounds way down here, then I'm like, ooh, this liver is probably enlarged. So we can use it for lots of different things. We got hepatomegaly, so it could be a million different things. It could be cirrhosis, it could be cancer, it could be, there's a bunch of different stuff it could be. All right, and then you're going to palpate. Now, nurses are only allowed to gently palpate. You cannot deep palpate, right? Because you don't want to pop an organ or something, right? So that's an advanced practice thing. You're looking for masses, tenderness, or guarding. So guarding is if their gut really hurts and you try to push on it, they're going to go like this, right? Like, don't touch it, okay? And then you just ask them, where does it hurt, right? But you can only do that very gently, and you're going to palpate like just like this, okay? Something's up. Yeah, but you need to find out where, because if we can find out where, which quadrant, then that tells me which organ is affected and it can kind of guide my diagnosis, right? Okay, let's go to right here where it says teaching. Okay, so when you're talking about just bowel health, you want them to avoid constipating foods, right? Cheese, meat, lots of carbs, and then iron is notoriously constipating. Everybody on an iron supplement is constipated. Avoid any gas producing foods, onion, cabbage, beans. Okay, so they're not super gassy. Everybody knows that one. You know, surgery and anesthesia can cause not only constipation, but also paralytic ileus. Now, constipation is not a red flag. I'm not reporting that. I'm expecting after surgery that they're going to be constipated. They've had anesthesia, they've had opioids, right? And a lot of times they've been NPO. So we already go ahead and start a stool softener or a laxative as soon as they come out of surgery because we already anticipate they're going to have opioid-induced constipation, okay? So if on an exam you see something like Which of the following four patients would be a red flag? And one of them says the patient hasn't pooped in 3 days. Every student wants to pick that. I do not know why. Okay. Nobody has died from not pooping for 3 days. Okay. So it is not that. Unless it says they have a rigid board-like abdomen, they haven't pooped in 10 days, right? The patient has a high fever. Okay. That's a different presentation. Okay. But I'm not going to call the doctor because the patient hasn't pooped unless they're super uncomfortable or something. Even then it's not a red flag. I would just like, hey, can you order some Colace or something? Okay. So that's not a red flag. All right, increase FFM. What is FFM?
Oh, fluids, fiber,
Fluids, fiber, mobility. Void at the same time every day, which basically just means sit them on the toilet at the same time every day, right? And that usually is first thing in the morning because most people have a bowel movement first thing in the morning, and then an hour after meals because an hour after meals, peristalsis should be going, and hopefully they'll have a bowel movement at that point. Always sit upright to defecate. Nobody can poop laying flat. Okay, so even if you have to put them on a bedpan or something, it should never be flat. Nobody can poop that way because it goes against gravity. It doesn't make any sense. All right. Let's talk about, now I just gave you just a very brief because this is a cheat sheet. We will cover these more in detail. Okay, but different procedures we may do for bowel elimination would be a suppository. Okay, an enema. Manual disimpaction, we got to go in and get it, right? Or we can either put on a rectal pouch, which like catches the poop in a little bag, or a rectal tube where we actually stick a tube up there and it allows the poop to come out through a tube.
that's not an ostomy.
No, that's still coming out of the anus. Okay, these are for patients that have like severe pressure ulcers in the perineal area or severe excoriation, something where if the poop touches their skin, it's going to be very bad for some reason. You can't, it's just like, remember we talked about the Foley, you can't put a Foley in for convenience, you can't put a rectal tube in for convenience. And you'll try to see this, or you'll see this a lot in ICUs. Because it's a pain to have to clean up poop from a patient who's intubated, sedated, right? All of that, that's a big giant pain. So a lot of nurses will be like, can we just put in a rectal tube? But can you imagine, that's probably pretty uncomfortable, even though they're unconscious, probably still feel something up your bum. Okay. So rectal tubes are really only if the patient has an absolute need for it. Okay. Yeah, like if there's something really bad that you have an indication for. Because you gotta think too, if you constantly have a tube in their bottom, anytime you put something in the rectal area or the anus, it makes some valsalva, which makes you push because your body knows like it's not supposed to go in, it's supposed to come out. And so you can cause some vital sign changes constantly having a tube in there. Not to mention, I'm sure it's super uncomfortable.
So would you pick like digital over that before doing that?
Well, the rectal tube isn't for constipation. It's for just patients who can't have any poop on their skin. Okay. Yeah, because they'll get irritated. All right, diagnostics I do cover on an entirely different sheet, but this would be something good to go back to before your test and make sure that you know each of these and be like, oh, I know what that means. Right?
I read some of this stuff.
Oh, good, good. All right, let's talk about constipation risk factors. We know the elderly are at risk. We know opioids slow the gut, so those are a definitely big one. After surgery, because they're on opioids and they've had anesthesia, which paralyzes your gut for a period of time. Okay. You already know immobility because of FFM. Low fiber diet, iron supplements, not enough water. If they have neuromuscular diseases, so that would be like multiple sclerosis or Lou Gehrig's disease, something that affects your muscles because your gut is a muscle too. So if you have a neuromuscular disease that causes muscular weakness, then your gut can't move very well, right? Antidiarrheal use. Remember, those are a no-go in nursing school. We do not give antidiarrheals to anybody, especially if they have some kind of bacteria in there, because we'll trap all the bacteria in there because we stop their gut, right? The only time in nursing school you can ever pick to give an antidiarrheal is if they have Crohn's disease, which is an autoimmune disorder, because they're pooping like 25 times a day. And and it causes major electrolyte imbalances and their bottom bleeds and they have major gut issues. So we will only do it for a short period of time just so they can function, because you can't even go to work if you're pooping 25 times a day, But if there's any virus in the gut, yes, if there's any virus in the gut or if there's any bacteria in the gut, you very well do not use antidiarrheals because you're basically slowing the gut and allowing that bacteria or virus to replicate. Yes. And then the last one we talk about is holding stool. Now, a lot of age groups do this, right? Toddlers do this because they don't want to stop playing. School age kids do it because they're too embarrassed to poop at school. Okay. Adults will do it if they're in like a work situation. Nurses do it because they don't have time to go to the bathroom, right? Older adults will do it because they may not make it there or it hurts when they go, right? So there's a fear there too. All right, let's go here to stool colors. Okay, so different colors you may see. You know, there's hardly ever a color that I'm going to freak out about. Okay, but you do need to know what stool colors mean, right? Anytime you see black tarry stool, that is a GI bleed. Okay, it does need to be reported. It's not an emergency. Okay,
That wouldn't be iron, too much
if
iron?
it's iron, they'll call it dark stool or they'll call it green stool. But
Oh,
anytime
okay.
you see tarry, that's digested blood.
Okay.
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 And so if it's black, then that means it is an upper GI bleed because it had time to go all the way through the lower GI and get partially digested, which is what makes it black. Okay.
Okay.
And that is called melena, which is actually a very pretty name.
It
But don't
actually
name
is.
a child that because it means black tarry stool. Okay. So that's an upper GI bleed. If it is bright red, okay, coming out of the anus bright red, that is called frank blood. It's a lower GI bleed, and the actual medical term for it is called hematochezia. Isn't that the grossest name
So,
ever?
yeah. So bright red is yeah, it's coming from the lower
Yeah,
GI.
because it's not been digested. It's
Yeah.
right there. So it's usually rectal bleeding or something very, very low in the GI. Some medications can turn the stool red, so you need to determine whether it's blood or not. And we will talk later about how to do that with an occult blood stool test that you can do right at the bedside. Okay.
Occult
Occult
blood
blood.
stool test is blood that's there but you can't see.
Yes, occult means hidden, right? If somebody's in the
Okay.
occult, it's hidden. Okay. If you see fatty or frothy stool, that is called steatorrhea. Okay. And that either means you have a gallbladder issue, a liver issue, or a pancreas issue because you're not producing the enzymes needed to absorb fats. So the fat is just coming out in the poop and it
Wow.
floats and it looks like fat.
Really?
It's very gross. Yes. Okay. If you see white or
But
clay
is it the
colored
normal
stool,
color? It's a normal color?
most of the time it's normal color. Yeah.
Okay.
If you see white or clay colored stool, okay, so it's like a grayish or white color, that means that there's liver disease. Okay.
Oh.
Because the bilirubin that your liver gets rid of goes into it breaks down bilirubin and then it puts it into your stool. And that's one of the things that gives your stool a brown color because billy is brown, right? So if you have liver disease and you can't break down the bilirubin builds up in your body, causing you to be jaundiced, right? And then none of it comes out in the stool. So the stool is white.
Okay.
Okay. So if you see white or clay colored stool, it almost always is liver disease. It could also be gallbladder because the bile does give some of the brown color too, but most of the time it's liver disease. Yeah. Yep. All right. And then I quickly gave you just a cheat sheet on different meds to know. Okay. I know y'all are not real big on pharm, but at least just to have kind of an idea. There are stool softeners, and that one's called polyethylene glycol.
No,
They
they did
did.
mention
Okay.
these in the book.
So polyethylene glycol is like Miralax. You heard of Miralax? So all that does is soften the stool, allowing it to swell. And then when it swells, remember it hits those nerves and then it tells your body that you need to go. Okay. Because you can't pass like a brick, right?
Wouldn't the stool softener be like Colace?
Colace is considered a laxative.
Colace?
A laxative.
Yeah, but they're not all peristaltic laxatives. So there are some laxatives that actually cause peristalsis and make your gut move.
Okay.
And then there are other different kinds of
But
laxatives
just like
too.
those little stool softeners that we give to people.
They're considered laxatives.
Really?
Yeah.
I didn't know that.
Yep. So different types of laxatives. And remember, these don't all cause peristalsis. Some of them cause the stool to swell. Some of them just make the stool real slippery, so it kind of slides through the gut. But you'll see Docusate, Bisacodyl. We give that in the hospital all the time. Cinna is another big one they give. That also comes as a tea. Okay. And then magnesium is a muscle relaxer. Okay. We remember that? Mag is a muscle relaxer.
Yes.
So it'll relax your gut and just everything comes out.
So
Okay.
is that like the most aggressive one?
No, it's just you have to take a lot of mag before you get to that point. Now you can get mag citrate like just over the counter at Walgreens. It comes as a liquid. You drink it. It's very sour. And yeah, I mean you're gonna go to the bathroom.
Wait, don't they give you that before a colonoscopy?
Yes, they can. Yeah. So depending on how much you drink, like some people take mag citrate every day. It doesn't cause diarrhea. It just is for to get their gut kind of moving. So it depends on how much you take. And then your two antidiarrheals. No. It would usually just be like if they were having a severe constipation issue or something like that. So the two antidiarrheals you need to know are diphenoxylate and loperamide. Now ATI and HESI love those drugs for some reason. Diphenoxylate and loperamide are your antidiarrheals. Yeah. And then remember that if you use antibiotics long term, that can cause C. diff. So if a patient's on long-term antibiotics, we always want to add a probiotic, right? And then laxatives are also not for long-term use, or you become dependent on them. right?
Mm-hmm.
The big thing that's testable about suppositories is that they need to go in the Sims position. That's like sort of on their belly with their leg up. Check them out.
So are they kind of on their sides?
Yeah, it's like my favorite sleeping position. They're like this and their leg is up. So you can like have access to their bum. Yes. And then make sure that you lubricate the suppositories first, otherwise that is very rude, and you can actually tear their rectum and the anus. So don't do that, okay? Okay, all right. Let's go right here in the green to diarrhea treatment. So if they have diarrhea, right, fluid electrolytes, remember sodium is the predominant electrolyte in the gut, so they would be losing sodium if it's diarrhea. Okay, so you need to look for hyponatremia. Daily weight is the best indicator of fluid balance. We know that. Make sure you do very good perineal care and good hand washing because most diarrhea is infectious, right? They may need a rectal tube if they do have skin breakdown or excoriation. Okay. It is preferable, even in diarrhea, for them to have oral intake before IV fluids. So if they're able to tolerate oral intake, we would rather do that than IV fluids. Okay. Because it's better for it to actually go into your gut, right? If they have diarrhea, we would decrease fruits, veggies, fiber, and put them on mostly carbs. Okay, carbs are the easiest for your gut to break down. Yes, crackers, things like that. That's easy for gut to break down. So if you're ever picking something nutrition and the patient has a major gut issue, not constipation because that's different, but if they have any kind of major inflammatory disease or gut issue, you're going to pick a high carb diet because it's hard for the gut to break down fat. It's too hard. So usually they'll go on low fat, high carb diet until that inflammation subsides. And then make sure they take in extra fluids, right? Because they're going to be losing a lot of fluids with diarrhea. Okay. And then let's talk about red flags down here. Rigid board-like abdomen. That's your number one big red flag for the GI system. Okay. That means they have peritonitis. That's called a surgical abdomen or an acute abdomen. The peritoneal cavity. Well, it's the whole cavity. If I took out all your abdominal organs, that cavity is called the peritoneal cavity.
Okay.
So all of that gets infected and inflamed.
Like the outline.
Yes, but it goes all the way to the back, right? Because your gut is in the front and in the back, right? So it's the whole abdominal cavity. Yeah, because I mean, you got to think like your gut's sitting right here, right? Yeah. So yeah. So rigid board-like abdomen, that's peritonitis. That is reportable immediately. Okay. If they have right lower quadrant pain, that's reportable immediately because that could be appendicitis. Now it could be other things too, ovarian cysts, things like that. But anytime they have right lower quadrant pain, we report that. Complete absence of bowel movements, mean they have not pooped at all. Their abdomen is distended. They have a fever. That could be signs of obstruction. But that would have to be like they have not passed anything. Nothing. No poop, no gas, no nothing is moving because they have an obstruction.
That would be like an emergency.
Yes, an obstruction I would report. Yes, because they're going to need to go NPO, IV fluids, NG tube, and surgery immediately.
That day.
Yes. Yes. If they have no bowel sounds and you have listened for 20 minutes total across the abdomen, then that could either be an obstruction, okay, or it could be a paralytic ileus that needs to be reported immediately.
Okay, so the paralytic ileus is when, because that's the small intestine.
It got paralyzed in surgery, right, from anesthesia and opioids, and it forgot to wake back up. So if your gut is not doing anything, that sends a signal to your brain, this organ isn't doing anything right now, so you can pull blood flow away from it. So it'll pull blood flow away from it, and then your gut will die. And that ain't coming back, right? So that's why paralytic ileus is such a big deal, because your gut will die. It'll get necrotic because your brain thinks you don't need it. It's not doing anything. It's not working.
Yeah.
Right? All right. Do we understand just the basics?
Yes.
All right.